to me, it seems all these drugs buy you time while we're working on the fundamental issue of cure. No? Am I oversimplifying?
Well, so, right, we're probably a long way from every person born with sickle cell disease in this country getting curative therapy. We have a long way to go before we're at that point. Okay. And so having all of these other therapies, right, I think, are appropriate. I mean, when are we going to get to the point where we're going to transplant folks with SC disease, but we still need therapies because there's a lot of morbidity and suffering there. Okay. So I think there's lots of room for the advancement and additional therapeutics coming out beyond just thinking about and focusing on gene therapy.
And as was pointed out, there is a morbidity that families make a decision about with these therapies with myeloablative right now. They have the same risk of other myeloablative busulfan things, veno-occlusive disease, thrombosis, hospitalization, platelet patients, and then the issue is patients want to make their own decisions. And as you would with a chronic illness, do you want to take these daily meds and not take the risk of a potential death, even though you have improved? There are family decisions that are individualized.
And it's not unique to this disease. There have been, let's go back 10 years, the classic New England Journal articles on cabbage surgery versus medical therapy versus stent. With a cabbage operation, you take all that risk and front load it. All these others, you're sort of incrementalizing the risk as you go out. Same decision, really, isn't it? No?
Depends on, I always think it's so individualized. I agree with Elliot. It depends on your values. I've done research in being risk-taking. So there are people that are more risk-takers. There are people who are less risk-takers. So it's so individual.
I think it's a classic question about sickle cell disease, right? When we think about how patients get treated in the emergency room, we're really all moving towards patient-specific treatment plans. And this is really, these discussions need to be individualized for each person and their families.
Based on my clinical experience, I can tell you the wrong way to treat them is periodically in the ER.
Oh,
Come in,
absolutely,
get something, go home.
That's
just wrong.
That's right.
And anything you can move away from that and toward these new therapies sounds to me better.
I've always thought ER was the worst place for a person with sickle cell disease.
And it's not the fault of the ER either.
No.
The system doesn't get them integrated well. What other agents are there out there in the pipeline other than what we've discussed that are looking interesting?
Well, I think it's, we could talk about like targets, I think, because there are multiple drugs for multiple targets. I think about those that modify the cyclic GMP pathway, and there are at least 3 I can think of, all oral. All oral medications, all I believe in phase 2 development. Early results are showing increases in fetal hemoglobin, possible increases in total hemoglobin, decreases in soluble P-selectin, but these are early, and as well as maybe some indication in markers of improvement in organ damage. So that's one class.
Okay, there's a class of drugs we haven't mentioned because we've all been talking about iron overload. Does chelation therapy play any role here?
Yes. Like Elliot has
Yeah,
the
it makes
most
it worse,
I do think there are other drugs going on.
Yes,
The
there are other
oral
drugs,
decitabine
yes.
with THU. There is actually a dramatic number of phase 1, phase 2 trials that are going on in sickle cell now, and that we could put out. But I do think there'll be other advantages to new drugs that can add to the armamentarium to how to treat sickle cell that are exciting. Iron, and I do support what you're talking about, iron overload, because no matter how you want to cut it, sickle cell patients are recurrently transfused for many reasons, many of appropriate reasons and some inappropriate reasons. And so iron overload is a common problem in sickle cell disease.
And we know that having iron overload makes the phenotype worse too. So.
Let's take a look a little bit now and ask, in terms of non-high-tech therapy, just general recommendations patients can follow on their own to avoid some of the complications of sickle cell disease. And these go back in time a long way, right?
I would say, number 1, find a person who knows how to take care of sickle cell disease.
Yes.
Find
Find a good
oncologist.
doctor.
Find a primary care provider who is specialized in sickle cell disease. You have to have that contact. That's okay, you see others, and even if you see that person once a year, but you have to find that person.
Okay. What about, I suspect, let me be deliberately humorous here, they shouldn't really climb Mount Everest. And
True.
well,
True.
not.
True.
There's an alternative to that argument that I just want to bring up, which is I've noticed and I think is true, is that one of the problems sickle cell patients have when they get older is they haven't developed necessarily healthy lifestyles with exercise, eating, and things. So actually, there's a fair amount of data developing now that, you know, for these diseases, that we need to focus on general health. And so exercise, I don't want to present the position that they can't exercise or eat well. And so there are so many people talking about the exposure to cold water or high altitude. The population as a whole hasn't been vigorously encouraged to meet the basic guidelines. So I do think they don't want to go mountain climbing, but I also think they need to do health-motivated care, which will help.
But, okay, again, this is what I do. I'll play devil's advocate again. You're going to exercise vigorously. Your end organs are going to get relatively hypoxic. You know, feel the burn. You know, you generate lactate.
We don't
You
tell
want them to do
patients
that,
to
right?
feel the burn, right?
we don't
tell
want
them,
that.
Right. So there are limitations and thoughtful exercise. But I also want to, right, the idea we tell patients to stay hydrated and
Yes,
all those other
exactly.
things.
Yeah.
And we tell them those things, not a lot of data. But I also, you know, when patients come in and say, oh, well, I didn't drink enough, or I don't think I drank enough, and they blame themselves for developing a vaso-occlusive crisis, they can happen even when you're doing all of the right
Exactly,
things.
exactly.
And we want to make sure patients don't feel like they're blaming themselves for the development of their
The
complications.
old blame the patient thing. You know, doctors do this, but it seems to me that's less likely to explain most of this.
Yeah, but the other thing that I would tell patients is to be an active participant in their care. Be your own advocate if you feel like you can't find someone close to you who can do that for you, because I think that that's helpful. Not everyone is going to find an expert,
That's right.
but if you can maintain proper knowledge about your disease and educate yourself on treatments that we've discussed today, that there's a lot that an individual patient can do to improve the course of their own lives.
And the American Society of Hematology is going to take the guidelines and make them into patient-friendly tools so that patients can become more aware of what they need to have done.